It's first of all a privilege to be able to facilitate this session today. We have a packed agenda. It's a really great list of speakers and panelists, and hopefully we'll also have some time for Q&A at the end of the discussion. It's an hour. It's going to feel fast because it's fast, and really just excited to hear from our speakers, our panelists, and to hear the thoughts and perspectives of the folks that are putting in questions into the event. If everybody agrees, I'm going to get started. I'm going to start with introducing our first speaker, Juan Pablo Uribe. He's the Global Director for Health, Nutrition, and Population at the World Bank. And I will ask that everybody read the panelists' bios. They're an impressive set of bios. We're not going to have time to go through all of them. So I'm going to hand it over to Juan Pablo to say a few opening remarks and open up the event. Thanks, Juan Pablo.
Jumana, thanks to you, and thanks to everybody for joining. A very special appreciation to Resolves to Save Lives, the whole team there, and also to our World Bank colleagues who have collaborated, coming together to be able to launch today this very important study. Also thanks to the panelists, by the way, which are going to be enriching the discussion. Some short thoughts from my side. A very basic one, but it's the mandatory starting point here, and in so many other health system strengthening and health sector discussions. Health workers are core to health systems. We wouldn't have health systems without the health workers who are caring for people within them. And many times we take that for granted. However, we really need, in all countries, regardless of the income level, we need qualified, motivated, sufficient health workers caring for their communities and the population. However, in many of our countries, including middle and high-income countries, we are facing a big deficit of qualified, motivated health workers delivering within health systems. WHO has projected a more than 10 million deficit in terms of health workers by the end of this decade. The drainage of staff from low and middle income countries to high income countries continues after COVID. And also coming out of COVID, many of our health workers are still very much unsatisfied or frustrated in their work places. And more important, they're facing incredible risks of infections, of disability and injuries, and in many places even of violence. COVID-19 was a very tough experience on this matter. In many places, in many countries, health systems were not able to do enough to protect the health workers who were protecting the population. And the shortage of health workers, because of them getting infected and sick, or even dying, just increased when more was needed out of their support and work given the pandemic. In addition to that increasing shortage, we saw in many places burnout, for example. I have a personal anecdote just to refer to, but I was leading a very big healthcare provider network in Chile and Peru. And I remember very well how we lost one of the best nurses in a high complexity hospital setting because she found throughout quarantines that she really wanted to spend more time with her family than sacrificing herself within a hospital setting, delivering care under very harsh circumstances. And that happened everywhere by thousands and if not much more. So countries need to invest much more on health workers. They need to protect them with the basic and sufficient equipment. They need to protect them with proper facilities, with water and sanitation, with infections control policies and procedures. They need to train them appropriately, and they need to permanently support them to care for others. Today's study And again, with a huge thanks to the authors, shows in a direct and very, I would say, crude way, the scale of the impact of not doing this throughout the first year of COVID. It has case studies from Kenya, from Eswatini, from South Africa, and from my own country, Colombia, by the way, providing a comprehensive framework of the true cost of infections and deaths among health workers in those communities, in those populations, looking in detail not only at the direct costs of such circumstances, but also the indirect consequences that their infections and their death implied for the rest of society by disrupted services, by impacts, indirect impacts among the most vulnerable, in particular women and children. I want to conclude basically saying that I really hope that being able to understand the true cost of failing to protect healthcare workers in our countries will be a permanent alert on our day-to-day work in the bank and in other institutions as we support strengthening health systems, so that we never forget that we need to start again with the core of our health systems, which is again investing in the health workers and protecting them to serve better in their duties. Jumana, let me stop here and go back to you, and you will be listening carefully to the presentation and the discussion and the panel, because again, I think this is very important for all of us to keep in our heads and to never forget again. Over.
Thank you, Juan Pablo, and thank you for really setting the stage, not only in terms of the importance of the findings within the report, but then the discussion that's starting to happen and continues to happen around the implications for taking the recommendations and the lessons forward. I'm going to now just present Tom Frieden, who will be providing remarks by video. Dr. Frieden, who many of you know, is currently the president and CEO of Resolve to Save Lives, who was unable to be here today, but has prepared a short set of remarks via video. So I'll hand it over to cue that video. Thank you.
This is the first report of its kind. It's comprehensive, it's important. We need to move beyond clapping for healthcare workers to protecting them. We need to recognize the enormous costs of failing to do so, costs that in low and middle income countries run into the tens of thousands of dollars for every single infection, costs that result in delayed care, deferred care, when patients can't get the services they need to stay healthy or get cured, costs in the dashed dreams of healthcare workers who perish from preventable infections. We must address this with three essential activities. First, policies that protect every person who works in every healthcare facility in a country. Second, protective equipment, an essential but insufficient aspect of protecting healthcare workers. And third, data, systems, and information to hold us all accountable for protecting people who protect and care for us so that they can be safer and healthier and societies can be safer and healthier. Thank you.
Great. So just another call for really moving beyond recognizing the issue to really a set of actions that we can all start to get behind. I'm going to turn this over to Weiwei Wang, who is the lead author of the report. I know with you and the team, this has really been a labor, if I can say, a labor of love. All of us are impacted by the issues around healthcare workers. Many of us are healthcare workers. And so I'm going to hand it over to you, Weiwei, to lay out the findings of the report. Over to you. Thanks.
Thanks, Jumana. I'll be highlighting a few key messages and takeaways from our study. So really representing a large team that is involved in the 4 countries that we work in, and also the colleagues from both the World Bank and the Resolve to Save Lives. Great. So next slide, please. As said, there is a detailed report available online. So I do encourage you to go to our website to look into the detailed methodology, data, and the results in these 4 countries. It's a country case approach, but we really want to use this to illustrate a global relevant issue. Next slide, please. So the first message we would like to highlight through the report is the economic impact of healthcare worker infections really go far beyond the healthcare workers themselves. So we developed a framework and a methodology to capture the relevant cost to the extent possible. Like I said, the cost of course is bear by healthcare workers, but also among those close contacts who are infected, their families, the patients that take care of. We call them secondary infections and deaths. And in addition, there's the general population. They are also affected by disruption of essential health services as a result of healthcare workers being sick and sometimes dying. Next slide, please. And based on that framework, capturing all these costs from different sources, the second message is the economic is too big to ignore. So when you have one healthcare worker gets infected or die, it's not just an extra COVID patient or COVID statistics. It really has a significant cost. So in this slide, we presented the cost per infected healthcare workers. And you can see it ranges from 10,000 per healthcare worker in Colombia to about 35,000 in Eswatini. Actually, in the 4 sites out of the 5, they are around $35,000. And if you compare with the per capita GDP in each of these countries, and then you can see that the ratio is substantial. And in Kenya, it's as much as 18 times higher. You might wonder why Colombia is a little bit lower compared with other countries. So there are 2 facts. One is the relative risk between the general population and the healthcare workers is much smaller than other study sites. And the Colombia, compared with other countries, they also have a much higher density of healthcare workers. So that adequacy helped to cushion a lot of the impact. Next slide, please. Again, we said there are different sources that goes beyond healthcare workers. And you can see that the cost from secondary infections and the service disruption, they are actually much, much more than the cost from primary infections among healthcare workers, as illustrated by the pink Turkish bar in the chart. So they are at least 2/3 of the total cost. And in Kenya and Eswatini, it's as much as 80 to 95%. Next slide, please. So this is a very, very quick snapshot of all these findings. In the report, you will find more information like the total economic cost, the share out of the total health expenditure, and so on and so forth. What does that tell us? Number one, these estimates, even though we said it's too high to ignore, they are likely to be underestimates because we didn't have data for private sector healthcare workers, for example. And we also didn't have data to take into consideration the disruption for NCD services. So, for example, we only focused on maternal and children health services. And we also couldn't take into consideration the medium and the long-term impact on the health labor market. As Juan Pablo pointed out, people may not choose this as a profession if the risk continue to be such high. The second takeaway is, as I said, through the Colombia's example, the impact tends to be higher when there is already chronic shortage of healthcare workers. which is actually the case for many low and middle income countries that most of us work in. And the last but not least, as has been remarked by Juan Pablo and Tom Frieden, such costs, they can be prevented when the higher risks faced by healthcare workers are reduced, neutralized through adequate protection measures, through infection prevention and control, through compensation, through all these shift arrangements among healthcare workforce. So we really need to prevent such inefficient costs in the future. It's a mandate for all of us. So with that, let me conclude the presentation and move on to the discussions we have arranged for every one of you. Thank you so much.
Thank you, Wei Wei, and thank you for a very brief overview of those compelling numbers and kind of what Juan Pablo was talking about. The numbers are stark and a bit harsh, but I think it's such an important entry point to start thinking about what do we do. I'm going to turn it over to Amanda McClelland. She's the Senior Vice President of Prevent Epidemics at Resolve to Save Lives. Amanda, it's nice to be reconnected again, and just wanted to give you a few minutes to reflect on the findings and the report to really set the stage for the panel. Thanks.
No, thank you so much, and thank you so much to the research team and the countries involved in simplifying what was an extremely complex methodology to help us really see those clear figures. Healthcare workers are really our first line of defense against outbreaks of infectious disease, and they play a critical role in identifying those outbreaks, providing care for the sick, and stopping the spread of the disease. But the impact that it has on them, I've seen firsthand in the work that I was involved in West Africa, Ebola, and other outbreaks, and especially in COVID. So seeing this firsthand, it's become a critical component of the work that we do at Prevent Epidemics for our whole team, and making sure that healthcare workers are adequately protected, that they're paid, and that they're supported as part of our defense systems for health security is critical. And it's not just for COVID. This happens in other infections, including Lassa fever, Ebola, tuberculosis, and MERS. So on a moral level, healthcare workers deserve to be protected. They risk their health and their lives to help people in need. But every healthcare worker that is harmed by a preventable infection is a tragedy, but also has an economic cost. On a practical level, they need to be protected. When healthcare workers fall ill because of lack of protections, the consequences go beyond that individual. This report shows it's expensive, but has long-term impacts across the health system and the community. An infected healthcare worker is at risk of infecting others in the health facility, in their home, and in the broader community. They're not able to provide other essential health services, which can have a dangerous ripple effect on the people that depend on their care, especially pregnant women and young children, which the report shows very clearly, especially in those communities that can ill afford the lack of access. And there's impacts around the workforce. As Juan Pablo said, we've seen a number of healthcare workers walk away from their passion and from their work. It's a huge loss, especially for communities where resources are scarce. And this pattern's repeated time and time again, leaving us ill-prepared to handle the next inevitable outbreak. We know how to keep our health workforce safe. This new report, we also have a better idea of exactly what it costs if we fail to do so. I hope to see these estimates of economic burden of healthcare worker illness used to justify some of the important interventions that Dr. Frieden outlined. We need clear and consistent routine data collection and analysis on healthcare worker infections and deaths that help us keep policymakers accountable and make the problem visible. We need investments in safer health facilities, giving them the resources to implement those infection prevention and control measures and control water and sanitation standards within facilities. And healthcare workers need training, tools, and resources to stay safe. So for those of you on the line that really work to advocate for healthcare workers every day, I hope this report provides yet another tool in our toolbox to help make this justification and drive for action. Thanks.
Thanks so much, Amanda, and really enumerating the multiple impacts on health workers, both on health workers and the multiple impacts within communities and societies that we're living in. So without further ado, and really the meat of the session, I want to introduce our esteemed panel. I'll start with Nanhal Nkongo, Nanhal Tracy Nkongo. Nanhal is a registered midwife in South Africa, and she's worked in a number of different areas as well as with private sector and public sector institutions. Nanhal, it's a pleasure to have you here with us today. Welcome. Keith Koote, who was appointed as the head of health for the Western Cape government on April 1st, 2020. Hi, Keith. I know you have a lot of experiences to share, just kind of getting put right in the middle of things. And Nan Chen, who is the co-executive director of Africa Frontline First. Again, welcome Nan Chen. And again, I invite participants to read about our esteemed speakers, but I wanted to get the panel discussion started. So maybe Nanhal, I can start with you. You know, importantly, this is a report that quantifies what the costs are and provides a way for us to think about how we can move forward and hold ourselves accountable in terms of the progress being made. But at the end of the day, this is all about people. And I just really want to turn to you and maybe put that people-centered lens as we kick off the discussion in terms of, you know, what were some of the impacts you saw and what were some of the couple of the ways that COVID and other epidemics have impacted you or others that you work with?
Good evening, colleagues. Thank you so much, Yuama. Firstly, it has affected the healthcare workers mostly in a psychological way, in a sense that they fear to attend to clients optimally. And then we feel that they have a demolished motivation and a sense of feeling helpless. And that results to a non-satisfactory relief, which causes a substandard provision of nursing care. As well, when the transition increases, it affects both the healthcare worker and together with the clients, because now there is a high demand and we are less staffed in so many cases. And we have been experiencing a delay and the provision of low quantity of PPEs and equipments, which also poses risks of cross-infection and reinfections. As a result, our healthcare workers tend to use disposable PPEs and they tend to use them, they are reusable because it's a measure of them trying to defend themselves against infections. And we have noted that during the pandemics, that's only when the ministry or the Department of Health feels the agency of providing us with the resources that are basic and that are very much needed. So it's only when there are eyes on us as a country, that's when the resources are fast-tracked and the turnaround time and is just fastened. Thank you.
Thank you, Nanhal. You're raising a lot of important issues around when do resources actually get dispersed and you know, kind of how that might not be adequate in terms of protecting healthcare workers and also the need for better and more sufficient PPE. So thank you for that, as well as the psychological costs. Keith, I'm going to turn to you. So you were kind of pushed into the Western Cape on April 1st, 2020, and in this role as the head of the department. And I just wanted to maybe talk to you a little bit or have you reflect a little bit on how the study has shown this high risk of infections and deaths in many sites, as well as the substantial cost. What was the most important action in your view that the Western Cape took to respond to the situation that was on the ground?
There are a few actions, but if you ask me the most important one, and part of my reflection is probably one of the saddest parts, reflecting from a middle-income country. The most important one, and everybody knew it at the time, was to vaccinate healthcare workers. Our delay in having access to vaccines meant that your study period, which was all the way from the 1st of March, 2020, till the 28th of February, on the 17th of February, was the first vaccination in South Africa. So that whole year, we had 2 weeks. And the 17th of February was the first vaccination in South Africa. And it was done in Khayelitsha Hospital in the Western Cape. And the first nurse got her vaccination. So I can tell you, you can say all the things we could do. The most important one was to vaccinate healthcare workers, but there was inequity across the world. It is sad for middle-income countries that we had to wait for all of that time before we could have access to a vaccine. And we did it under research conditions, under the Sisonke trial, to get J&J vaccines, not actually release vaccines to actually do it. So for me, that's the most important action. I can talk about the 2 or 3 other actions which we did in the absence of the vaccine. The first one was our occupational health and safety policy and our employee well-being policy is a key thing that came to the fore, because our nurses, frontline healthcare workers, community health workers, the anxiety and the fear was the biggest thing that influenced people's behavior. And the sense of having to be protected from a PPE perspective quickly shifted to other things. But we realized that our biggest response was to do a complete overhaul of our occupational health and safety policy and our employee well-being policy at the same time. So we have a very deliberate and intentional program, which now looks at employee health and wellness in a very holistic way for all our healthcare workers across all our platforms. It's a pity that it took something like COVID for us to really put that to the fore. The third thing is we did an HR strategy. I'm very key. I'm hearing from Nonsley the issue, but what we did deliberately is we employed people on contract. And it was interesting that your study found that, because one of our biggest and data was, sorry, I'll come to the HR strategy because linked to our last one, which is data. We really invested in data capability. And one of the biggest things that our data capability showed us right at the outset, we did predictive models of healthcare worker infections. And we set up a data system to track healthcare worker infections. And one of the things that we, from the outset, then predicted is at the height of your waves is going to be the time when you have the most healthcare workers affected and people in quarantine and in isolation. So you're going to have the lowest number of available staff. So that's one of the first predictive models we did. And we then intentionally employed people on contract to cover for those let's call it the peaks and troughs. So as the wave went up, the healthcare worker numbers go down. And we then mitigated in terms of that as a proactive strategy. But as you can hear from this, I believe one of the biggest things that we did in the Western Cape, and I'm very fortunate for it, we invested in data capability before. And we could track per healthcare worker individually, whether they've had a COVID test, whether they were infected. So our data is very accurate because we have a very complete data set. And actually another thing which in your data doesn't come out, but I mean, I'll just mention it to you, is at the peaks, and I'm pretty sure it would have happened in the other 3 countries. At the peaks, we deliberately and intentionally switched to a policy of not doing PCR testing on the whole population. But we continue to test healthcare workers, and we continue to take the test at risk populations. But we didn't do the total population. So even your numbers of total infections are blunted in the peaks because we intentionally shifted. There was not enough PCR testing in the third world country to be able to continue that amount of testing all along. Sorry, I got a bit carried away, but you asked for one important thing. Thank you.
Thank you, Keith. And I think just to maybe reflect and invite other panelists to reflect as well, just in terms of, you know, being in the context of urgency and what you try to do and the kind of innovations that you do and the ways of working hold so many lessons for how we can do something differently at scale. And you know, the point on data, I couldn't underline it even more, is, you know, what are the investments we're making during the times where there aren't consistent crises to make health systems more resilient and more people-centered. So thank you for that. Nan, I'm going to turn to you now. You know, a lot of the discussion, I think, and really the implications around making health systems more people-centered, and obviously for the population, but also for health workers and enabling communities and health workers to thrive. So you're really at the heart of the community health worker agenda with your role. And I'd love to get your perspectives in thinking about, you know, how do we enable people-centered health systems? How are the perspectives and the involvement of community health workers shaping the discussions on safety, on health worker safety? And where do you see the potential to do more in terms of empowering this, you know, critical, essential cadre of people and ensuring that they're more center and part of those discussions?
Thanks, Jumana. Thank you, Keith and Nonle. Your perspectives are really important. And I just want to build on something you mentioned, which is many folks in a crisis do innovate. And I'm so proud of the innovation that we've all had to do to survive and thrive and accomplish and respond to crises like COVID-19. I'm proud of those innovations, because I am deeply disappointed that we've had to innovate in the first place because of the underinvestment, the underplanning in our health systems in the first place. To bring the community health worker piece into this, a lot of what Nonle you described in your experience about of the eyes of the system are only on us when there's an emergency, and the supplies are only there when the crisis is there. That's exactly what's happening with many of the community health worker cadres across the world, across the continent of Africa, and those where I work in. These community health workers are deeply embedded within their community. They hold the trust of their neighbors and are able to provide lots of essential services, basic primary health care. They're on the front lines, but they're also at the back of the line when it comes to being paid or protected often. These community health workers are the first to respond and yet the last to receive PPE often. One of my experiences was during the beginning of COVID. We were working with our government partners on assessing what kinds of services at the community level could still be provided if they were modified, right? And of course, modification requires still getting gowns and gloves and masks. And while across the board in all the countries we were working in, we would see that community health workers and other frontline health workers like nurses as well, were absolutely part of the rapid response plan. When I looked at the procurement tool to buy PPE, oftentimes the community health, not even a selection, not even allowed to be on this is a very banal example of an Excel tool that speaks to the injustice of our systems. And why is that the case? In so many cases, in many places, community health workers are still informal. They're not part of the formal system. They're not counted. And I saw even in the study that you presented, which is an incredible data for all of us, incredible data for our toolkits. And yet, even then, it was difficult to find data at the community level. And so I think one of the pieces here, just to call out, is in the end, during COVID-19, some of our partners got together and did an initiative called the COVID-19 Action Fund for Africa, where they were able to reach almost 500,000 CHWs, around 479,000 in total, with protective equipment, 121 million units of protective equipment. Amazing innovation, but that's 121 million units of PPE, almost 500,000 CHWs that should have been counted in the first place. And so what I would leave here to say is, in order to protect community health workers, they need to be counted first. And they need to be more part of the formal systems that we're all building and building back better.
Thank you so much, Nan. And these are some of these root cause issues that we consistently talk about and try to focus on. And what is the thing that's going to move that needle and accelerate that move towards more people-centered resilient systems. And it's a critical ask, and I think a critical call to action for everybody on this call and beyond. Maybe just thinking about, what's next after this. I'd love to just turn back to Nanhal on a question around, your role as a nurse. So you focus a lot on infection prevention and control, and you have a long and very varied career. So you've seen many dimensions of the health worker agenda come to play. I don't want to say what's one policy or practice, but what's a high impact policy or practice that would make the difference for health worker safety today?
Thank you so much, Jumana. So firstly, I would like to allude that South Africa has put an IPC policy in place, which was recently amended in 2020. So which was just before the pandemic. So this policy just stipulates the minimum basic standards that needs to be adhered to with regards to IPC. And then secondly, I would say the most policy would be the policy on waste segregation and waste management. So this, I find this policy being the key because it enables the healthcare workers to adhere to proper waste disposal, which will also prevent needle prick injuries as well. And I would say the practice that really stood out for me was the hand hygiene. So the use of alcohol-based hand rubs, especially in disadvantaged communities, has been the key to IPC. So imagine having no water provision. So the hand sanitizer, the alcohol-based hand rubs really came in handy. And then we developed a 1 minute hand hygiene initiative, whereby you'd find healthcare workers, they would gather around for just that 1 minute, just perform hand wash together, singing along, and it just became fun. Everybody was just singing along, practicing all the steps to follow during hand wash. And then one would wonder why, because these people are healthcare workers, why are they practicing this? So now just imagine back, you have been in a dilemma of not having water provision. So now at least you are trying to adapt. So you've already adapted to that situation. So now things are changing around. We have this alcohol-based hand rubs and the water is available. So at least now we're coming back together. We're trying to memorize all the steps, and everybody is just reminded, and we are quickly adhering to it. And everybody is just constant and complying with the hand wash procedure as well. And that also proved that it improved compliance with hand wash, because everybody was doing the 5 moments of hand wash, was reminded that each and every time after attending to one client, I have to perform hand wash, and then placing the posters and job aids of hand hygiene next to every basin, next to everywhere that we display our hand sanitizers also as well, assisted in that way. And then the importance of PPEs, having our healthcare workers being mandated to wear them, and then constant trainings to reinforce the compliance of wearing PPEs and the correct use of PPEs as well.
Thank you so much, Nanhal, and just raising the questions, and I think putting a spotlight on something we all know, but worth probably voicing, that health service delivery and health is inherently a multidimensional issue, and particularly in the time of multiple crises in this context we're living in. How do we ensure that the enabling environment for healthcare workers to be able to protect themselves is there and in place? So thanks for those reflections. Keith, I'm going to turn it over to you. So, Nanhal really gave a great perspective from the healthcare worker side. When you're looking in terms of looking forward, in terms of what you've learned, there's a lot of stuff that has happened that has been very negative. There's also glimmers of hope and a lot of action and accelerating action. And there's a particular moment in time that we're living in. So as you think about, the path forward, what are the types of support that governments need? And I know you're involved in those types of discussions as well. And just drawing on your experiences and reflections would be very valuable.
No, thank you very much for that. I think to understand the kind of support governments would need, you have to understand the complex environment within which a healthcare system's challenges are surfacing. So I liken it to societal challenges, and I liken it to challenges within the healthcare system, and then challenges which is very, very localized and contextualized where people find themselves. And it's not either or. I think that's the point that's been made, so it's not about the highly specialized hospital and the neurosurgeon being looked after, but the community health worker being neglected. It's about understanding that a healthcare system is a very complex animal. It has multiple manifestations, and it's not immune to societal challenges that plays itself out. Having taken all of that, I would like to say, and I know a study like this points out what we could have done better or should have done better in preparation. But I like to take it from the point of view that the context, at least where I find myself, we've been extremely positive about what we've learned. I would say it is that COVID has humbled us. We've been able to learn what it is we could have done better before. But more importantly, it's not to waste the opportunity of learning to put new things in place. And from that perspective, becoming a learning organization has been absolutely crucial to what happens in my specific situation. Being intentional about making innovation and a learning organization the purvey of everyone. It's empowering people. It's addressing the power issues in the healthcare system. A community health worker should have a say, should have a very important say, should have a voice, should be heard, should be given the opportunity to table that. Now, unless you actually address what I would call the power dynamics in a healthcare system, unless you start addressing the societal drivers that sits behind it, unless you start looking at reforms in a meaningful way, it's very difficult to come in and say, what support do you need? For me, therefore, the most important thing from a government perspective, and I don't think anybody else can step into it. I've gone into multiple places. Governments must show stewardship. There's nobody else that can do this stewardship. And I firmly believe in it. So I come from a place being the head of the health and wellness department in our setting now, but I'm being invited in by the head of government in this province to lead the safety initiative, to lead the initiative on mental well-being for society. It's on the basis of the data capability, but it's on the basis that we're stepping into a stewardship role. So I have to appeal to people, right? Because I understand the context, because I'm in a very fortunate situation that we've had a well-functioning system. COVID has helped us to accelerate a lot of the let's call it the functioning in our system. We're getting 5 clean audits in a row. We're doing all the administrative things well. We got good data capability. We invest in our people. We're doing culture work. We're doing all of that. People are excited to work in our system. So I'm in a fortunate position where I can work in a functioning system. But I'm also in a position where I can say, for people that is not in that position, what is it that they require to get to the position of privilege where we are in? And that is to allow people to be their own stewards, to allow them to step into, to take ownership. If you are coming from outside, believe in the agency, invest in people's capability to make decisions for themselves, support them. So it's supporting, it's enabling. That's the kind of things that's required. And this thing about actually people stepping into stewardship and owning their problems and owning their solutions is where I believe the excitement comes from. So if you have to ask me very high level, I would say a systems approach to doing things. Too many global agencies come with fragmented interventions and comes with interventions that fragment the system further. I can tell you it's damaging to a healthcare system. In our system, I can gladly say to you now, we don't have a single designation of somebody that is a disease-specific coordinator. But it doesn't mean we don't look after TB outcomes. It doesn't mean that we don't have maternal health outcomes. It doesn't mean, but we don't have a disease-specific coordinator because we've orientated ourselves to a life course orientation, to social care systems, to investing and all of those. So let the local people take charge, allow them to take charge, ask them what they need, support them with the ability to establish their own policy trajectory, and listen to them when they say vaccine inequity is not okay. Listen to them that the resource inequity between the North and the South is not okay. Be open and listen to those things. Thank you.
Well, Keith, thank you so much. And, you know, we can have a virtual coffee later. That the systems approach is music to my ears as we really think about how do we get to scale on some of these things, and how do we ensure systems that can both be resilient, of course, but also adaptive. There's so much we don't know. How do we plan for different scenarios in the future? What does that look like? And how do we ensure that the people that need to be centered are centered in the context of also a planet that needs care as well? So thank you, Keith. That was incredible. Nan, I'm going to turn over to you, and then we'll open it up for I'll bring in some of the Q&A questions. You know, we've been talking a lot in different ways about a systems approach and people-centeredness. Transforming financing mechanisms and thinking about financing and the economic costs, of course, is one piece of the puzzle to deliver on health worker protections. What is, in your view, some of the good practices or the best way to cultivate political support and champion such reforms? So, you know, over to you on that.
Yeah, that's such an important question, because it's hard, especially if some of us are working from the technical side of the world and seeing why isn't my politician understanding all this evidence I'm putting in front of their face. And I love, Keith, your point about the systems approach. I feel like you were reading my mind or copying my homework on this. In terms of cultivating champions, maybe to make it very short, treat humans like they're humans. That's it. I think maybe, I don't know if this has ever happened to you, Jumana. Sometimes I'll talk with my partner, my wife, and she'll, I'll say to her, I just heard from a friend of mine that I should really probably lower my caffeine intake, and maybe I won't, take so much coffee all day long. And the look on her face when she tells me, I've been telling you that for half a year. And when your friend tells you that you listen to them. So I think when we think about cultivating champions, think of them as people. Often we have, as technicians, we think a lot about the message and the evidence that we're bringing, but maybe think also about the messenger or the medium. Like, is this going to be a presentation or maybe a real experience? Talking not to me, but maybe somebody like Nonleo, or showing them the work in person, and thinking also about the moments of opportunity, the moments when what you're trying to convey actually matters to a politician or to somebody in power and influence. So yeah, treat people like humans, because we're all human, and we all have that side of ourselves. I would also, when we think about authority often and how to mobilize these big initiatives or big change, we often think about presidents and high-level ministers. And from our perspective, we're so pleased to be working with folks like former President Ellen Johnson Sirleaf, or with the Africa CDC. Those are really great people with formal authority. But I would not underestimate, do not underestimate those as other types of authority, experience, moral authority. A few months ago, we were in Monrovia, in Liberia. They were hosting the third annual Community Health Symposium. It was the first of these symposiums that actually almost every country delegate brought community health workers themselves to the symposium itself. They were on every single panel. You could see that there were a third, maybe a quarter or a third of the full room. And when you're sitting there alongside those frontline health workers, you experience the world differently. I think you sort of almost by osmosis take on some of those concerns. And by the end of that conference, setting aside the academic papers and the panel presentations, by the end of it, the vice president of the country was making verbal commitments to bring more health workers on payroll. and the people, the messengers in that moment made a real difference. So don't forget people power as well.
Thank you. And really just also echoing some of the pieces around Keith's reflections on also shifting power and how that can happen in a meaningful way as well. Okay, I'm looking at the time. We have probably time for 2 questions. So again, we'll encourage participants to put their Q&A into the chat. The report team will, be getting back with the summary of the discussion. So hopefully they will be able to answer some of these questions as well. Keith, I do want to turn it over to you. We've gotten from a couple of people, including Abdallah from Uganda and Namanya, regarding compensation for healthcare workers. How are, a big issue has been that these impacts happen, then the health workers bear the cost of the illness, the cost of the treatment. How do you think about insurance packages? Has there been anything done in the Western Cape that's really looking at that, or how are you thinking about it?
Yeah, it's a crucial point. And the point I was trying to make about the social context where people live. Many of our healthcare workers, including community health workers, come from the same suffer from the same socioeconomic conditions that our patients would suffer from. And the reality is income and the squeeze on the income of everyone is a big challenge socioeconomically now across the world. Coming out of COVID, I mean, we are now dealing, and we just call it almost like this is our second COVID. So we're becoming very used to our stresses and shocks to our system. The financial crunch that we're in is a big stressor to our system. It's a shock to our system currently, because we are sitting in a very, very difficult situation. So part of the remuneration of employees is very much in terms of what is the remuneration package for employees, how that is negotiated. It is done through chambers and the organized labor and all of that. What we did is we looked at the cost of the cost that the person incurs because of COVID. So we did a few things. Firstly, obviously, nobody's remuneration was discontinued. So everybody continued getting the salaries. The second thing, most healthcare workers are on state-sponsored medical schemes. So a lot of their healthcare costs would be covered through their medical costs. So we made sure that that is covered. And on top of all of that, if anybody was in any financial hardship, we looked at specific tailored programs for people to support them. When we started the Employee Wellness and Wellbeing Program, the first thing we learned, and our healthcare workers told us, actually extended to our families. So we have an employed contractor that would kind of give you coaching and counseling and all of that. But it was not just for the healthcare worker, but it was for the whole family of the healthcare worker. And so there are many things that you look, but I think our point is very much to what you said earlier. Our healthcare worker, and this is it's not a slogan that we use loosely, our healthcare worker has moved away from what in our system is called a personnel number, that's your personnel number, to a human being. So we treat our healthcare worker as a human being, like all of us want to be treated. The same as we want to move to the situation where our patient is more than a folder number, but a human being that we serve. So there's multiple things, but the notion that we are connected as human beings and we have our humanity coming forward and we are there for one another, that kind of almost like a social solidarity is one of the biggest things that our healthcare workers come back to us. So it's still tight at the end of the month. We're still struggling. We're still looking at the remuneration, but we're part of a family and we're part of a system that cares for us. And actually, by you showing us that you care for our families enough to be able to extend the support, those are the kind of things that we believe is a social package to support our staff members.
Thank you, Keith. I'm looking at the time and I want to make sure that we can finish on time. I do want to maybe just open up 30 seconds of reflection from each of you in terms of what you would hope that participants take away from both the report and the implications of the report. What's the one kind of statement or thought or piece you want them to take away. I'll just give each of you a few seconds to respond to. So Keith, I'm going to keep you to the one thing on this one. So whoever wants to start, please come in, and then we can turn it over to the next speaker.
I don't mind going first, and then others can go. So I think if there's one thing that you need to take away is that people matter. So for me, if we go to people matter, it is about how do we relate to another human being and bring humanity back into healthcare. People matter. Let's care for one another like we want to be cared for ourselves.
Thank you, Keith. Nan?
I would say every life matters, regardless if you are a caregiver or you are a client, or everybody matters. So the moment that you take that personally, that is when you'd be able to provide efficient and sufficient quality involvement within the team.
Thank you, Nan.
Yeah, thank you for all these perspectives and insights. What I would take away here, with gratitude to the Resolve team and Buhe, like this is great evidence. This is great data we can add to our toolkit, and I would say internalize it. I think I don't know about others, but it also makes me a little frustrated at how, you know, the economic cost is so clearly and so stark compared to what it would cost to prevent and protect. So you get frustrated and take action.
Thank you, Nan. I really appreciate those perspectives. I'm going to turn it over very quickly to Amanda to say a few closing remarks, and just want to also give huge gratitude to this panel. It was really a great discussion, and thank you for the privilege for being able to facilitate it. Amanda, over to you.
Thank you so much. And I think the panel really wrapped it up. It's about people, but taking action and using that frustration to really drive change, and empowering everyone from the community health worker and the communities all the way up to policymakers to make sure that this becomes a priority and that we learn those lessons. So I'd just like to thank the panelists. We're extremely grateful that you've shared your perspective on this important topic. It's really helped make the numbers of what is a very complex economic study really come to life. I also want to thank the guests and the participants that joined us today to really learn more about the study. And I think just to close in saying, echoing Nan's statement, this is one more piece of the puzzle that we hope re-emphasizes the clear and consistent message we've been giving across the board for some time now. And so we hope this contributes to many of the advocacy efforts of the partners across the board. And a huge thanks to World Bank for really leading this project and helping us build the evidence base to help prioritize healthcare workers and their safety.
Thank you, Amanda, and huge thanks to Juan Pablo and Weiwei and the team. I think having a true champion as our global director, a doctor who has dealt with a lot of these issues firsthand, and so very much looking forward to the follow-up on this report. Thank you, everyone.